Bismillah ar-Rahman ar-Rahim. My name is Midhat Muhammad Hagras. I'm consultant internal medicine, chief of internal medicine service in Al Salama Hospital, Al Khobar, Saudi Arabia. Today we'll discuss some topics related to diabetes mellitus, which is very common in our practice. Diabetes mellitus is not only a disease touching the carbohydrate and lipid and protein metabolism, but it also affecting all body systems. It makes a challenge for each physician to deal with complication of diabetes. It makes also a challenge for each physician to deal with the common problems and management. Management itself is a challenge for each one. I hope that in the coming few minutes, we'll discuss together the magnitude of the problem of diabetes, and we'll put some light on the only one complication, which is a cardiovascular complication of diabetes mellitus. Type 2 diabetes mellitus is always associated with cardiovascular risk, which is the greatest risk in all complications of diabetes mellitus. To know the magnitude of the problem and to approach the solution for this problem, we'll go through this data. Global burden of diabetes mellitus, number of people with type 2 diabetes mellitus is increasing in every country. In 375 million people have diabetes in 2014. By 2030, rising to 552 million. 80% of people with diabetes live in low and middle income countries. The greatest number of people with diabetes are between 40 to 59 years of age. But why diabetes is increasing? Ethnicity, family history are always implicated in the problem. Closely associated with overweight or obese people, increased switch to Western diet and lifestyle. So obesity and genetic component and Western life always associated with increased predominance of type 2 diabetes. Almost all patients with type 2 diabetes are resistant to insulin. Resistant to insulin action leading to first overproduction of glucose by the liver and underutilization of glucose peripherally. So, relating to the statistics, UKPD, which is the United Kingdom Prospective Diabetes Study, both insulin resistance and impaired beta cell function are present in the time of diagnosis of type 2 diabetes. Newly diagnosed patient has approximately 50% of normal insulin sensitivity and 50% of normal beta cell function. So type 2 diabetes is a dual problem. Insulin resistance is the first problem, and subsequently insulin secretion is coming lower by time. And the end result will be increased fasting blood sugar, increased the postprandial sugar, and increased HbA1c. Progression of type 2 diabetes also and related complication always coming as a story. First, insulin resistance increasing. So level of insulin comes lower. Beta cell function also comes lower. Then hepatic glucose overproduction. And postprandial glucose increase, fasting blood sugar increased, HbA1c increased, then coming the stage of complication, development of microvascular and macrovascular complication by time. So, always remember that beta cell function progressively declines with progression of the disease also. This decline in the glycemic control is accompanied by decreasing beta cell function regardless of type 2 diabetes mellitus treatment, and this is why the problem. In all modalities of treatment, always coming the disturbance of function of beta cell. Diabetes mellitus is not only a metabolic disorder, but it's also is associated with a lot of problems associated with basement membrane problem and endothelial dysfunction. Diabetic retinopathy, which is a leading cause of blindness in adults. Diabetic nephropathy, which is a leading cause of end-stage renal disease in adults. Stroke, 2 to 4 folds increase in the cardiovascular mortality and stroke. Cardiovascular disease, 8 of every 10 individuals with diabetes die from cardiovascular events. Diabetic neuropathy, also a leading cause of non-traumatic lower extremities amputations. Progress of cardiovascular risk in type 2 diabetes always comes in 3 stages. Stage 1 comes before the diabetes onset, the stage of insulin resistance or impaired glucose tolerance, genetic susceptibility, environmental factors, nutrition, obesity, and physical inactivity, with subsequently hyperinsulinemia, decreased HDL cholesterol, increased triglycerides, and atherosclerosis and hypertension is always associated with the insulin resistant and impaired glucose tolerance. Just diabetes starts, immediately the ongoing hyperglycemia is associated with the complications. So atherosclerosis, hyperglycemia, hypertension, retinopathy, nephropathy, neuropathy, and a lot of complications. This complication, the end stage will be disability, blindness, renal failure, congestive heart disease, coronary heart disease, amputation, and death. Always remember that weight gain and cardiovascular comorbidity is always associated with diabetes mellitus. So weight gain always leading to cardiovascular disorder by hypertension, by dyslipidemia, by increasing the triglyceride, increasing LDL cholesterol, decreased HDL cholesterol, hyperinsulinemia and insulin resistance, impaired glucose tolerance and diabetes, prothrombotic state like the factor 7 abnormalities and fibrinogen abnormalities, and pro-inflammatory state. The most important fact that in the medicine that associated with less weight gain, the same medicine that associated with less diabetes and less heart disease. So always there is a link between diabetes mellitus and cardiovascular disease. The medicine associated with low weight gain is always associated with less diabetes and less heart disease. We have a target. We have to target this score to control the diabetes and subsequently controlling the metabolic disorder. So blood glucose, the blood pressure, the body weight, and lipids always associated with better performance, better quality of life, and less complications. Cardiometabolic risk control, avoiding weight gain, hyperglycemia will be reflected to 70 to 80 of mortality reduction in patients with type 2 diabetes in the form of microvascular disease, which is the commonest cause of death in diabetic patients. Systolic blood pressure and cardiovascular death are strongly related. Cardiovascular mortality is always associated with all stages of systolic blood pressure. If we add diabetes to this risk factor, we'll find that the mortality of cardiovascular problems always associated with diabetes and hypertension rather than hypertension alone in all stages, even for controlled. Diabetes also increasing the risk of cardiovascular events and death in hypertensive patients. So major cardiovascular events are always associated with hypertension and diabetes more than hypertension. Cardiovascular death is always associated with hypertension and diabetes more than hypertension. Hence, the importance of the vascular complications. Vascular complications of diabetes account for the majority of the social and economic burden among patients. 50% or more of our patients of type 2 diabetes will die prematurely of a cardiovascular cause. Cost of patients with microvascular complication approximately 3 times higher than patients without it. So we are dealing with a big problem, big medical and financial problem. Major cardiovascular events are always less in intensive medication for diabetes rather than the standard medication. So the total microvascular events is 9.4% in the intensive medication compared with 10.9 in the standard medication, with 14% relative risk reduction in all risk. New or worsening retinopathy also is in the standard medication is 6.3 compared with 6% only in the intensive medication and 5% relative risk reduction. Nephropathy also is 4.1% in the intensive medication compared with 5.2% in the standard medication with 21% relative risk reduction. So the help you are doing for your patient to reduce this risk always reflected with all total risk reduction and mortality reduction also. Always remember that renal impairment occurs in the 3/4 of diabetes. Renal events, reduced clearance, macroalbuminuria, double clearance. Risk of 1 year mortality in the diabetes based on nephropathy, we are dealing with a big figure. With patient with no nephropathy, 1.4% death. Microalbuminuria, 3%. Macroalbuminuria, 4.6%. Elevated plasma clearance or renal replacement therapy, 19.2%. So with progression of the disease, always we have higher mortality rate. Let us do some focus on the nephropathy. Albuminuria is a strong predictor for all-cause mortality, particularly from cardiovascular disease. Incidence of renal failure is 6/1,000 persons per year. 1/3 death, 2/3 going for dialysis, and 50% will die within 3 years. So the patient is not controlled now. If he's coming in this category, you will not see your patient anymore after 3 years. 20% of diabetic patients will die from other causes of renal disease. Diabetes is a leading cause of end-stage renal disease. 50% of patients receiving renal replacement therapy. So this is very big figure. Diabetic kidney disease, this also has stages, 5 stages. Kidney damage with normal or increased glomerular filtration rate is more than 90. Kidney damage with mild decreased glomerular filtration rate, 60 to 90. Moderately decreased glomerular filtration rate, 30 to 60. Severely decreased glomerular filtration rate, 15 to 30. And kidney failure less than 15 or dialysis. Diabetic kidney disease, before we are calling it diabetic nephropathy, is a new term used to classify the chronic kidney disease presumably caused by diabetes. This is a very big category. Although kidney biopsy is required for definite diagnosis of diabetic glomerulopathy, screening of patients with diabetes can identify most cases of diabetic kidney disease in our outpatients. Going to screening for diabetic kidney disease among diabetics. There is a program for screening to diagnose, to follow up, to know and expect your prognosis. Routine screening for diabetic kidney disease in patients with diabetes is recommended to begin 5 years after the diagnosis of type 1 diabetes. At the time of diagnosis of type 2 diabetes, with repeated testing yearly thereafter. Approximate screening tool include measurement of the urinary albumin-creatinine ratio or AC ratio, serum creatinine, and estimation of glomerular filtration rate. To be repeated at least annually, testing for microalbuminuria should be in stable glucose control. Avoid marked hyperglycemia when you are doing the screening, with no urinary tract infection, fever, or systemic infection. In the first morning urine sample, avoid post-exercise sample. Avoid also congestive heart failure and marked hypertension, and for pregnant women. Confirmed by repeated positive test, at least twice within 1 to 3 months, sensitive and specific test. Presence of elevated urinary albumin excretion is the hallmark for diabetic kidney disease diagnosis. Microalbuminuria, AC ratio 30 to 300 milligram per gram creatinine or 30 to 300 milligram per 24 hours. Macroalbuminuria, AC ratio more than 300 milligram per gram creatinine or more than 300 milligram in 24 hours. This is considered a more accurate determinant of renal dysfunction and diabetic kidney disease than serum creatinine, which unfortunately is widely used in our outpatient clinics, especially in the early stage of diabetic kidney disease, stage 1 and stage 2, and there is therefore preferred to be a screening tool. Serum creatinine should therefore be measured at least annually in all adults with diabetes, regardless of the degree of urine albumin excretion. Serum creatinine should be used to estimate glomerular filtration rate and to stage the level of diabetic kidney disease if present. For HbA1c application, HbA1c now is very important for prognosis of diabetes. And although we are not using HbA1c for diagnosis of diabetes only, but must be in addition to the blood glucose level, but we have to know as an estimate of average glucose if you are faced with HbA1c only without random blood sugar or fasting blood sugar. If you find HbA1c is 6, it means that the estimated average glucose is 126, 7 around 154, 8 is 183, 9 is 212, 10 is 240, 11 is 269. This is average estimate. So if when you are doing your HbA1c for your patient every 3 months, you can predict to which extent your patient is controlled as a diet control. HbA1c is not only related to the plasma sugar, but it is associated also with the risk of vascular events and death. HbA1c and annual cardiovascular event rate, every 1% reduction of HbA1c associated with 26% reduction in microvascular events, 22% reduction in macrovascular events. HbA1c also is strongly associated with annual death rate. So each 1% reduction in HbA1c is associated with 22% reduction in all-cause mortality, 22% reduction of cardiovascular death. Again, for UKPD, which is a standard study, significant risk reduction for type 2 diabetes complication with each 1% reduction of HbA1c. 1% reduction is a great sum. So 1% reduction of HbA1c is associated with 43% reduction of macrovascular complication, 37% reduction of microvascular complication, 21% death-related diabetes, 16% congestive heart failure reduction, 14% reduction of myocardial infarction, and 12% reduction of stroke. So 1%, it is very helpful for your patient if you can apply. So any medication claiming that we can reduce the HbA1c is 1%, it means that you are at your patient this protective measures. HbA1c also is associated with a lot of complication. Microvascular complication and myocardial infarction is directly associated with the HbA1c. More HbA1c, it means more myocardial infarction rate and microvascular disease. The less you are getting with your patient, it means that less incidence of microvascular disease and myocardial infarction. UKPD event rate for select endpoint with tight versus less tight blood pressure control. Tight blood pressure control for diabetic patient is always associated with less microvascular complication, less stroke incidence, less all diabetes-related death, and any diabetes-related endpoint. Considering that tight means that less than 140/80, and less tight means that 150/85. In HOT study also, there is significant benefit from intensive treatment with diabetic subgroup, major cardiovascular events, which is directly associated with target diastolic blood pressure, while approaching the target or diastolic blood pressure with less incidence of cardiovascular events. The problem is always coming more with diabetic patient. You are in need for more tight or more lower diastolic blood pressure figures. In elderly patient, there is also systolic hypertension, the influence of diabetes on cardiovascular event rate. Always the 5-year events in all cardiovascular events is strongly associated with diabetes. It is higher in diabetic than in non-diabetic, and coming even with diabetes with active treatment is always lower than placebo or standard medication. In progress, stroke by medical history for all participants, we'll find that the rate of stroke, if we compare the active management related to the placebo or the standard, will find that in diabetics there is less incidence of strokes in active management arm rather than the placebo arm. Even in non-diabetics, also in the active management is less than the placebo arm. In INVEST Diabetes, which is a great study conducted on 6,400 patients, no benefit of tight versus usual control, which was very strange, this data. Tight control means less than 130, and usual control, it means that between 130 and 140, and not controlled over 140. They find that with a usual control, rate of non-fatal MI, non-fatal stroke, and all-cause mortality is okay. So even if you can reach with your patient to a usual control, which by the way is very less percentage all over the world, you will get also very good benefit for your patient regarding the MI, the stroke, and all-cause of mortalities. This is collective of most of the famous studies is associated with blood pressure control and outcome in type 2 diabetes. Always you will get benefit when you are controlling your blood pressure in the type 2 diabetes mellitus. Now going for a very important section, which is management of type 2 diabetes. Type 2 diabetes mellitus management is always a challenge for all physicians. This challenge comes with the variable figures of the patient, the difference between the patient, the different lifestyle of the patient. No single medication can give all results for all patients. Lifestyle change is always coming. The upper hand, taking the most important factor for managing the diabetes. You are not sure to which extent your patient is controlled his life. You are not sure that to which extent the patient applying the physical exercise in his daily practice. You don't know to which extent this patient is stressful, has a stressful job, or has a stressful life. Regarding the body weight, the body mass index, a lot of factors affecting your management. So it's always come as a challenge. You are in a speed. You want to win. If you win, you'll take your patient to the safe side. Starting from the guidelines, actually, it is changed in the last few years. In 2009, there is a start of the change of the guidelines, applying new modalities of treatment which is not known before. This era, we can consider this as era of DPP-4 application. That time, although there is no large scale of molecules applied, there's also the studies was very limited as the duration and number of patients, but there is very interesting finding in this American Association of Clinical Endocrinology and the American College of Endocrinology. They put an algorithm. That algorithm, you'll find some changes in the practice of the physician subsequently. DPP-4, although at that time it was a new group, comes in the first stage of HbA1c 6.5 to 7.5. And you'll find that in this stage of patient, the sulfonylurea, which take the upper hand in management of diabetes for many decades, coming now at the second stage. And DPP-4 replacing not only the sulfonylurea, but sharing all modalities of treatment in all stages. This start in 2009 was the first breakthrough of a change of the practice of diabetes, change of the definition of diabetes, and the change of clinical implication. Coming after lifestyle measures, considering the first line of metformin, then second line comes sulfonylurea, then basal insulin or premix insulin, alpha glucosidase inhibitor, or DPP-4 inhibitor. So coming as a second line or a third line, basal and then basal meal insulin. Coming also for some alternative modalities, sulfonylurea or alpha glucosidase or metformin, if it's not the first line, alpha glucosidase, DPP-4, GLP-1 analogs. So this practice, I think this is start of a change of practice of the physician all over the world. Then the American College, the American Association of Clinical Endocrinology, they put also a new algorithm for adding or intensifying the insulin. This application also is put in April 2015. This start with basal insulin, which if your HbA1c is less than 8, and total daily dose is 0.1 to 0.2 units per kg. And if your HbA1c is more than 8, you can apply 0.2 to 0.3 units per kg. And titrate your insulin every 2 to 3 days with much or approaching the glycemic goal. If you find your patient going for hyperglycemia, you can reduce 10% or 20% of, or if you have fixed dose insulin, you can reduce by 1 to 2 units. And if you find your patient going to hypoglycemia, you reduce your doses. If your patient coming for hyperglycemia, you can add some few units every 2 to 3 days. But if your patient is still not controlled and you have persistent hyperglycemia, you have to intensify your regimen by adding GLP-1 receptor agonist and or add prandial insulin. Going for criteria for diagnosis of diabetes. HbA1c is less than 6.5. Now the figures, this is changed. Before we are diagnosing after 7, now we are diagnosing after 6.5, and even the normal HbA1c now 4 to 5.6. Between 5.6 to 6.5, we can find this impaired glucose tolerance or pre-diabetic state. Fasting blood sugar is more than 126. 2 hours plasma glucose more than 200, or random blood glucose more than 200. And don't forget that the criteria for glycemia plus the clinical manifestation coming before the HbA1c, which is a confirming method for diagnosing the diabetes mellitus. We can't rely only on HbA1c as a diagnostic tool for diabetes mellitus, because a lot of fallacies comes with HbA1c, a lot of physiological state also affecting the results of HbA1c. Treatment goal, you have to put a goal or a target with your patient, establishing and maintaining the effective control of glycemia in patients with type 2 diabetes mellitus is essential for long-term prevention or delay of diabetic complications. Post-meal and post-challenge hyperglycemia are independently associated with the following in people with diabetes: macrovascular disease, retinopathy, cancer, impaired cognitive function in elderly people with type 2 diabetes, increased carotid intima media thickness, decreased myocardial blood volume and myocardial blood flow, oxidative stress, inflammation, and endothelial dysfunction. Treatment with agents which target post-meal plasma glucose reduced vascular events in primary prevention. Targeting post-meal plasma glucose and fasting plasma glucose is an important strategy in achieving optimal glycemic control. Diet with a low glycemic load are beneficial in controlling post-meal plasma glucose. Several classes of pharmacologic agents preferentially lower post-meal plasma glucose. Post-meal plasma glucose level seldom rise above 7.8 millimole per liter or 140 milligram per deciliter after food ingestion in healthy non-pregnant people. Self-monitoring of blood glucose is currently the optimal method for assessing the plasma glucose level. So nowadays we are sharing our patient for control of their diabetes. We are giving some instruction for the patient, encouraging the patient to do self-monitoring at home. Then even without reporting to the physician, they are adding or decreasing for the units of the insulin. Post-meal glucose level is very important. Post-meal blood glucose is early detectable glycemic abnormality, or the earliest forever. Post-meal plasma glucose correlates with HbA1c. Targeting post-meal blood glucose may improve overall glycemic control. Elevated post-meal blood glucose is associated with the development of vascular complications. So we can put the post-meal plasma glucose or blood glucose as a target for our diabetes control. For our glycemic target, HbA1c must be less than 7, and pre-prandial must be less than 130, post-prandial must be less than 180, and there is some individualization. tighter target for 6 to 6.5 for younger and healthier, looser target 7.5 up to 8 in older and comorbidity or hypoglycemia prone. And always we are putting this strategy for all our patients. Initial therapy, whatever will be the line of management, you have a lot of options. Advancing to dual combination therapy, adherence or advancing to triple combination therapy, transition or titration to insulin. Therapeutic options, lifestyle always comes the first line. Weight optimization, healthy diet, increased activity level. This is very important up to the degree that the lifestyle change sometimes, if it's implicated in the pre-diabetic stage or impaired glucose tolerance, can delay the progress of type 2 diabetes or the onset of diabetes up to 70%. Oral agents and non-insulin injectable, we have metformin, you have sulfonylurea, you have TZDs, DPP-4 inhibitor, GLP-1 receptor agonist, alpha-glucosidase inhibitor, bile acid sequestrants, dopamine 2 agonist, and other medications. In short, we'll put some light on the advantage and mechanism of these products. For biguanides, this activate cyclic AMP kinase, decreased hepatic glucose production, with advantage of extensive experience for all the physician, no hypoglycemia, and weight neutral, and maybe it has a lower rate of cardiovascular disease. But it has some advantages: gastrointestinal, lactic acidosis, B12 deficiency, and some contraindication of some renal patient. But cost is low. Sulfonylurea, also it closes the potassium ATP channels, increased insulin secretion, extensive experience with all physicians, decreased microvascular risk, but it has some advantage. Hypoglycemia is a definite cause of dissociation of the medicine, weight gain, low durability, it's ischemic, maybe ischemic preconditioning, and low cost. TZDs, increased insulin sensitivity, no hypoglycemia, durability, decreased triglyceride, increased HDL cholesterol, and decreased cardiovascular like pioglitazone. But also it associated with weight gain, edema, heart failure, bone fracture, and some myocardial infarction like rosiglitazone, and bladder cancer for pioglitazone. And the cost is high. Alpha-glucosidase, it inhibits alpha-glucosidase, slow carbohydrate absorption. It has some advantages with no hypoglycemic episodes, non-systemic, decreased postprandial glucose, and decreased cardiovascular events. But it has some disadvantages like gastrointestinal, dosing frequency, modest decrease of HbA1c, and moderate cost. DPP-4 inhibitor, it inhibits DPP-4, increased GLP-1 and GIP, no hypoglycemia, well tolerated, modest decrease of HbA1c, maybe there is some possibility of pancreatitis and some allergic reaction. Cost, up till now, the cost is high. GLP-1 receptor agonist, it activates GLP-1 receptor, increase insulin, decrease glucagon, decrease gastric emptying, and increase satiety. Advantages: weight loss, no hypoglycemia, maybe affecting beta cell mass and cardiovascular protection. Disadvantages: gastrointestinal, pancreatitis, injectable form, and the cost is still high. Insulin always comes as a master treatment, activate insulin receptor, increase peripheral glucose uptake, universally effective, and unlimited efficacy, decrease microvascular risk, and always coming as a malleable dose. Hypoglycemia comes the first disadvantage, weight gain, mitogenicity, injectable, and needs training and stigma of insulin injection. And the cost is variable. Accordingly, this therapeutic regimen, we have some medication is strongly associated with hypoglycemia, like metformin, like acarbose, like glargine. others associated with weight gain, like glimepiride, ribaglinide, glargine, and NPH, and aspart regular insulin. And some medications are associated with definite cardiovascular risk. So current therapy we had that time is associated with weight gain and or with hypoglycemia. So raising the question, why we need DPP-4 inhibitor and GLP-1 agonist? This is the answer. Metformin is a cornerstone and prevents from cancer, but fails with time and has tolerability issue like GIT upset. The sulfonylurea have side effects like hypoglycemia, weight gain, and may cause accelerated beta cell failure. TZDs may have severe side effects like heart failure, myocardial infarction, osteoporosis, fluid accumulation, weight gain, and cancer. Current combination therapy do not halt the progression of the disease. No one can claim that form. Insulin therapy will always be instituted too late because of the side effects like hypoglycemia and weight gain and inconvenience, and although it is still the best option. So many patients can't achieve the target or maintain satisfactory glycemic control with existing agents. So most therapy are associated with weight gain and hypoglycemia, which adding a big burden for the physician towards his patients. So that's why we got the new type 2 diabetes mellitus model. This new model includes overweight and obesity, insulin resistance and qualitative and quantitative defect in the insulin secretions, and dysregulation in the secretion of other hormones. DPP-4 inhibitor and GLP-1 agonist. This diagram shows the mechanism of action of DPP-4 inhibition. Increase the active GLP. Always comes after meals, intestinal GLP-1 release. Active GLP-1 comes with DPP-4. If we block this DPP-4 by DPP-4 inhibitor, the end result will be active GLP-1 will increase instead of going to inactive GLP-1. GLP-1 action, it stimulates the insulin secretion, inhibits glucagon secretion, delay gastric emptying and reduce appetite, and preserve beta cell mass, cardioprotective and cardiotropic effect. GLP-1 has multiple direct effects on human physiology. DPP-4 always conducting their action through the GLP-1. In the pancreas, it increases the insulin secretion, glucose dependent and beta cell sensitivity, increase insulin synthesis, decrease glucagon secretion, which is glucose dependent, and increase beta cell mass. For the brain, decrease energy intake. For the liver, decrease hepatic glucose overproduction. And for the gastrointestinal tract, decrease the motility. Metformin and DPP-4 combination addresses the three core defects of type 2 diabetes in very nice complementary manner. B cell dysfunction, hepatic glucose overproduction, insulin resistance. This is the core of the problem. DPP-4 inhibitor increase active incretin to improve markers of beta cell function and increase insulin synthesis and release. DPP-4 inhibition also indirectly reduce the hepatic glucose overproduction through GLP-1 mediated suppression of glucagon from alpha cell. Metformin acts as an insulin sensitizer. Metformin significantly decreased hepatic glucose overproduction by directly targeting the liver to decrease gluconeogenesis and glycogenolysis. So if you add metformin to the DPP-4, you are counterattack the three mechanisms for production of hyperglycemia and complication of diabetes. So gliptins and metformin are always very strong combination. Treatment strategy implementing combination therapy with gliptins and metformin result in superior glycemic control versus metformin monotherapy due to low rate of addition of hyperglycemic agent. So if you are applying this combination early to your patient, you may be not in need to add any other medication, and you may stop the stage of the diabetes as a preclinical stage or the impaired glucose tolerance stage only, not to over diabetes. DPP4 inhibitor therapy for type 2 diabetes, it improves alpha cell and beta cell function, clinically meaningful reduction in the blood glucose, fasting, postprandial, HbA1c with low risk of hypoglycemia, compatible with first-line therapy, predictable additivity to other agents, especially metformin, weight neutral, better than all other agents except metformin and the incretin mimetics, but with fewer side effects, potential to alter disease progression, beta cell protection, and cardiovascular. In the coming few slides, we'll apply some clinical studies for the synergy between the DPP4 and metformin on prandial GLP-1 glucose. Vildagliptin, which is one of the best molecules for DPP4, it increases active GLP-1 levels by 2 to 4 folds through inhibition of DPP4 enzymes. Metformin raises the GLP-1 level through increasing GLP-1 synthesis and not through the DPP4 inhibition. And vildagliptin and metformin are known to have synergy to maximize the level of intact GLP-1. So effect of vildagliptin and on prandial active GLP-1 level in drug-naive versus metformin-treated patient is very evident. So you'll find active GLP-1 is much higher in vildagliptin patient with metformin than even the vildagliptin alone. There is also strong synergism between DPP4 and metformin on fasting GLP-1. Fasting level of intact GLP-1 at baseline and after 3 months is very evident if we are adding vildagliptin for the patient for the intact GLP-1 compared with placebo. And for patient receiving vildagliptin full dose 50 mg BID with metformin, the fasting level of intact GLP-1 in vildagliptin subgroup after 3 months is even over than vildagliptin alone. DPP4 also add on to metformin is associated with a strong reduction of HbA1c over 24 weeks. DPP4 enhance beta cell function and improve postprandial glucose when metformin alone is not sufficient. So beta cell function is markedly improved with vildagliptin full dose 50 mg BID with metformin compared with vildagliptin 50 mg twice metformin. And 2 hours postprandial glucose is always coming much better with vildagliptin full dose with metformin. DPP4, if we are added to metformin, no weight gain overall. So you are applying a new system of medication, new group with definite impact on the fasting blood sugar, postprandial blood sugar, beta cell function, and GLP-1, and without any weight gain. Special category of patient with the diabetic kidney disease. Blood sugar control in the diabetic kidney disease is very important. But the question is which drug to use? Drugs contraindicated metformin, which is a basic medication for all patients. Glibenclamide is not safe with diabetic kidney disease as its dose needs to be reduced. Gliclazide, ribiglanide, biglutazone are safe and can be used without dose adjustment, and insulin occasionally used. Second generation of sulfonylurea, gliclazide, no dose adjustment, glipizide, no dose adjustment, glibenclamide, better to be avoided, glimepiride, reduced dose or avoid. So you still have problem of all groups of sulfonylurea. DPP4 inhibitor and GLP-1 receptor agonist is a promising blood sugar control results with very safe profile. Another group of diabetic patients, blood pressure control in hypertension and diabetes. Blood pressure for hypertensive diabetic comes 15% controlled only compared with 85% uncontrolled. So this is the magnitude of the problem. So If you want to solve the problem, you have to do powerful blood pressure control as a first target. And your choice of antihypertensive agent diabetic patient is based upon ability to prevent adverse cardiovascular events and slow progression of renal disease if you can. Treatment must be tailored on individual basis considering drug class benefit, history of adverse events, additional medical conditions like diabetic kidney disease, ischemic heart disease, and patients with financial limitation. And the blood pressure management is always an art. Renin-angiotensin system management, this ACE inhibitor or ARBs come the first choice. Calcium channel blockers, diuretic, beta blocker with cardioselectivity also come sometimes on other choices. The initial prescription, the drug class demonstrated to reduce cardiovascular disease events in patients with diabetes, coming the priority. Multiple drug therapy, more than 2 agents is generally required, starting with 2 drugs for patients with baseline blood pressure more than 20 systolic over 10 diastolic millimeter Hg above the goal. Kidney protection is a key target in the management of hypertension and diabetes. Always considering your patient endangered by the kidney problem. If you want to put your patient on the safe side, you have to control the blood sugar and to prevent as you can the kidney disease. Treatment objectives in the different stage of diabetic kidney disease. The first stage of microalbuminuria with cardiovascular risk factors, this is a stage of prevention. The tight blood sugar control and tight blood pressure control, you can keep the patient at this stage or preventing this patient from going to the other stage. Macroalbuminuria with the target organ damage, this is stage of regression if you diagnose your condition and you put early management of strict diet, strict medicine for diabetes and hypertension. Otherwise, your patient will go very fast to end-stage renal disease with associated clinical condition, and this is a stage of retardation. European Society of Hypertension in 2010 raised a very important question. This question was, does use of antihypertensive treatment to reduce microalbuminuria translate into effective benefits on outcome and mortality? It was a reappraisal of studies with renal endpoint in type 2 diabetes. Big studies conducted at that time, IDENT, RENAL, ERMA2, ADVANCE, DIRECT, and a lot of studies just to answer this question. And of course, the answer was yes. Use of antihypertensive treatment, it was associated with marked reduction of microalbuminuria and it translated to strong benefits on outcome and mortality. Lowering blood pressure reduced the renal events in type 2 diabetes in all studies. European guidelines on hypertension management, a European Society of Hypertension Task Force documented in diabetic combination treatment is commonly needed to effectively lower the blood pressure. Renin-angiotensin system should be always included because of the evidence of the superior protective effect against limitation or progression of nephropathy. So if you have a diabetes or hypertension, please recognize your problem very early, apply the convenient medication, protect your patient against going for renal disorders. So powerful blood pressure control for hypertensive diabetic patients is a triple action on the renal level, cardiovascular protection, and total mortality reduction for life-saving benefits. Coming to this important data, this tight blood pressure control versus tight glucose control. Tight blood pressure control in diabetic patient comes with lower microvascular complication incidence, lower diabetes mellitus death, any diabetic endpoint, and less stroke. Finally, some important points to remember. Type 2 diabetes is associated with 70 to 80% chance of premature death due to cardiovascular disease and cardiovascular stroke. The ADA guidelines state that all patients with diabetes mellitus and hypertension should be treated with ACE inhibitor or ARBs as a first-line therapy. According to UKPD, each 10 millimeter Hg decrease in systolic blood pressure associated with a reduction of 15% of diabetes-related mortality, 10%, 11% myocardial infarction, 13% of microvascular diabetic complications. According to ADA, recommendation for renin-angiotensin system blockade is an important component treatment of patients with diabetes and hypertension. According to ADA, recommend target blood pressure in diabetic patient to be less than 140/90, and it is usually achieved by 3 or more class of drugs. Type 2 diabetes, which is linked to weight gain and obesity, is a complex disease that predisposes patients to cardiovascular disease. Better understanding and appreciation for the role of the incretin system, the pathogenesis of type 2 diabetes, has led to the development of incretin-based therapies such as GLP-1 receptor agonist and DPP-4 inhibitors. The possibility that one of the gliptins may emerge as a first-line treatment in combination with metformin in newly diagnosed patients with type 2 diabetes remains possible and may materialize into recommended future guidelines. I hope I put some light about this difficult figures. We are dealing with a big challenge for diabetes and its associated cardiovascular complication, touching our daily practice and endangering our patient. We are putting all our knowledge and efforts and experience just to protect our patient and to prevent the progression of the disease. I think our rule is always coming forward in the stage of prevention, better than going for the second prevention. Primary prevention always taking the upper hand for all our management as a professional. And I hope this collective data is useful for all our juniors, and hoping that it will become with benefit for our practice and our patient. Thank you.